We just a case of inguinal hernia. Now it's time to discuss about the operative session on inguinal hernia. Presented by Dr. Deepang Gattani, who is a second year junior resident at Apollo Clinical Hospital. So Deepang, you are ready?
Yes, sir.
And Amara Melgan may join. He is busy somewhere. We might join. We'll continue. Okay. Before we start the upper part, is that is considering the case. So,
Sir,
the
voice is breaking.
Deepak, you can hear me?
Yes, sir. No.
Yeah. So anatomical landmarks are important. So we discuss about the anatomy little, and then we pass on to the different techniques of angioplasty steps. So Deepak, what is the inguinal canal? What is the anatomical landmark of inguinal canal? Deepak, we can hear you.
So your voice is breaking. Can't understand.
You did not heard my question? I asked,
No, sir.
what is the anatomical landmark for inguinal canal? Where is the inguinal canal?
Okay. Inguinal canal is just above the inguinal ligament, in between the fold
What
of
is that area?
the external oblique is and the posterior boundary of the inguinal canal.
Where is the location? Inguinal canal is an area
In between the superficial
which
and
is in
deep
the groin,
inguinal vein.
and the groin is the junctional area between the ab. Am I clear? Inguinal
Yes.
canal is in the groin, which is the junctional area between the domain.
Hmm.
And what is the extent of inguinal canal? Where does the inguinal canal extend from?
It extends from the superficial inguinal ring to deep inguinal ring. Yeah,
Yes.
just
And the
above the inguinal ligament.
length, length.
Around 3 to 4
What is the
centimeter.
length of the inguinal canal? It is described as 3.8 centimeter. Okay. So the which extend from the superficial inguinal ring and about 3.8 centimeter in length. Okay. Where is the deep ring?
Deep ring is in
What is the
the,
anatomical landmark for deep ring?
it is the internal opening of the inguinal ligament, which is at the
Yes.
just above the midpoint of the inguinal ligament.
At
Yes.
this is an opening in the inguinal canal which is
Hmm.
located between two important landmarks, between the anterior ciliac spine and the symphysis pubis,
Yes, sir.
which is half inch above the inguinal ligament. Okay. As you draw the line between the anterior ciliac spine and the symphysis pubis, as you draw the line, between the anterior celiac spine and the symphysis pubis, and you find the medial between these two is the Medial between the anterior spine and the symphysis pelvis. Just a minute. There is some audio. Hello. Am I audible?
Yes, sir.
Okay. So it's a mid-inguinal point, which is a point in the groin crease, and 1.25 centimeter above the mid-inguinal point is a deep inguinal ring. Where is the suboficial ring? What is the boundary of the suboficial ring? What is the boundary? Debunk. What is the boundary of the suboficial inguinal ring? Debunk, you are muted.
It is 2 centimeter above and medial to the pubic tubercle.
What is the boundary?
Boundary, it is anteriorly bounded by the inguinal ligament and posteriorly by the lacular ligament
Then
and
the
medially.
suboficial ring, try to understand. The suboficial ring inguinal ligament does not come. And pubic tubercle is on the landmark. It's not too medial to that. The suboficial inguinal ring is bounded on each side by the two crura of the extrinsic aponeurosis. And these two crura is attached. You got my point. Once you have this extrinsic appearance coming towards the suboficial inguinal ring, it splits into the crura, infralateral crus and the supremedial crus. And in between the two crus, medially the crus is attached to the symphysis pelvis and laterally it is attached to the pubic tubercle. And what is this ridge between the two crura, which forms the floor of suboficial inguinal ring? There is
Pubic
a bony
crest.
fine ridge.
Pubic crest.
Pubic crest. Good. So the suboficial inguinal ring is bounded on either side by the two crura, and the floor is by pubic crest. What are the boundaries of inguinal canal itself? Inguinal canal has got a anterior wall, has got a posterior wall, has got a floor, has got a roof. So what is there anteriorly in the inguinal canal?
Anterior wall is made up the external oblique aponeurosis, and in laterally there is external oblique and internal oblique.
Yes.
And
so external aponeurosis throughout and reinforced laterally by the muscular fibers of internal oblique. Anterior. Posterior is by?
Posteriorly is by fascia transversalis.
Throughout and reinforced medially by?
Conjoint tendon.
Conjoint tendon. Yes, that goes behind the inguinal canal. That's cord structure.
And roof is formed by?
The floor is formed by?
Inguinal ligament.
And the most medially?
Lacunar ligament is
lacunar
there.
ligament. Yes. So the floor is by this inguinal ligament. If you go trace the inguinal medially, the lacunar ligament comes in relation to this inguinal canal. Or is the roof? Roof is formed by?
Conjoint tendon. And laterally transverse abdominis also.
Arc fibers of both. Yeah. Arc fibers of internal oblique and lateral abdominis. Okay. So this is the inguinal anatomy as you see from the front. Okay. So the inguinal anatomy, which is from anterior to posterior. As you go to the laparoscopic hernia techniques repair, you will find you are not looking from outside. You are looking from inside. So once you are doing a laparoscopic repair, the anatomy is little different. And you orient yourself to the new anatomy, which is seen from the interior of the abdomen. If you go by transabdominal peritoneal repair, you find the peritoneal lining first. And there are some landmarks which helps you to go into the repair of hernia laparoscopically. So as you go into the peritoneal cavity, you find there are three important landmarks. One in the midline, one lateral to that, and another lateral to that. These are peritoneal folds raised by some ligaments. So what are the three important folds or ligament as you see from the peritoneal aspect? Deepank, what are the three important ligaments you look at from the interior of the abdomen?
Median umbilical ligament, medial umbilical ligament, and lateral.
What is that? What structure is there inside this ligament? What is that structure? Median umbilical ligament is in the midline.
Yes.
This contains
obliterated
urachus.
Urachus, yes.
Oblique urachus. Okay. What is this next structure lateral to that?
Medial umbilical ligament.
Yes. Which is formed by?
Obliterated umbilical artery.
Good. As you trace laterally, you find another fold.
Lateral umbilical ligament.
Formed by?
Inferior epigastric
vessels. Okay.
vessels.
So these are the three important landmarks you look at from the interior. Median umbilical ligament formed by urachus, medial umbilical ligament formed by the obliterated umbilical artery, and lateral umbilical ligament formed by the inferior vessels. Now, if you take these three landmarks, you have three defined areas which are described as fossae. Where is the supravesical fossa?
It just be in between the medial umbilical ligaments.
And in between the median and
medial umbilical.
Yes. So the area between the median umbilical ligament and the medial umbilical ligament, either side, will be called as supravesical fossa. Where is the medial inguinal fossa? Medial inguinal fossa.
In between the medial and lateral umbilical ligament.
Yes. Which hernia occurs through the medial inguinal fossa? Which hernia occurs through the medial inguinal fossa?
Indirect inguinal.
No. Where is that area? This area is between the medial umbilical ligament and the lateral umbilical ligament. That is the medial inguinal fossa.
It is direct.
Yes.
Direct.
So that is a site for direct inguinal hernia. And where is the lateral inguinal fossa?
Yeah, in between the lateral umbilical ligament and ASIS.
ASIS. So that is the area called as lateral inguinal fossa, and deep ring is there. So hernia through this site will be
indirect
inguinal hernia. So keep in mind these anatomical landmarks. Okay, you have supravesical fossa, where supravesical hernia may form. You have medial inguinal fossa through which direct inguinal hernia comes out, and you have lateral inguinal fossa through which indirect hernia occurs. Now, there are some more important landmarks as you go by laparoscopic approach. The deep ring is seen and identified by looking at the lateral umbilical ligament. And as you look at the lateral umbilical ligament, you find two important structures emerges through that. One is a vas deferens, which comes up and then turns medially towards the lateral pelvic wall. And you find these testicular vessels which runs and go up in the retroperitoneum. What is the boundary of triangle of doom? What is the boundary of triangle of doom? Deepank, you are muted. Deepank, you are muted. Yes.
Yes, sir. Sorry.
What is the boundary of triangle of doom?
Triangle of doom is bounded by iliopubic tract above.
No.
Iliopubic
No.
internal ring is above.
Iliopubic doesn't come in triangle of doom. Triangle of doom starts in the deep ring. Apex of the triangle is the deep ring, where the vas deferens and the testicular vessels emerges.
So medially is vas deferens, laterally by the gonadal vessels,
and
and below
the
is by the peritoneal fold.
is apex. No, 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 no. A triangle has got three sides. Okay, and one base and the apex.
Base
Okay,
is by the
peritoneal fold is
peritoneal
covering this
deflection.
Then I am asking you the boundary. You say the boundary. Boundary is vas difference, gonadal vessels, and line joining the vas difference and the gonadal. This triangle of doom. Why this area is called as triangle of doom?
It has external iliac artery and veins.
So if you are dissecting in this area, you should be cautious. If you injure this major vessel, it will have a disaster outcome. Okay. So where is the triangle of pain?
Just lateral to the lateral to the triangle of doom, there is triangle of pain, which
So
is
lateral to the gonadal vessels. And you
yes.
started dissecting from the anterosubiliac spine. Okay. What important nerves run in this triangle of pain?
Femoral
Define
nerve,
nerves. We can identify.
femoral nerve, femoral branch of
Femoral nerve is
genital.
more posterior. You don't dissect the femoral nerve. What are the more important nerves which comes in dissection of this area?
Lateral femoral cutaneous nerve of thigh,
Yes.
anterior femoral cutaneous nerve of thigh, and femoral branch of genitofemoral nerve.
The genitofemoral nerves comes. What nerve you found on the lateral side of this area? You delineate a muscle. Psoas major muscle. What nerve lies in front of the psoas major muscle?
Genitofemoral nerve.
Yes. So whole genitofemoral nerves comes in relation to this triangle of pain. And as you look from inside, if you go deep to the peritoneum, what is the lower limit of this external oblique aponeurosis? If you see from the front, that is the inguinal ligament. The fossa transversalis gets thickened around the lower border of the inguinal ligament, the whole external oblique aponeurosis. We call that as iliopubic tract.
Iliopubic tract.
Okay. Iliopubic tract is the thickening of the fossa transversalis along the lower border of the external oblique aponeurosis. So these are the important structures you will come across while going for laparoscopic hernia repair, be it TAPP or TEP. Okay.
Yes, sir.
Where is the Cooper's ligament? Where is the Cooper's ligament? What is the disposition of Cooper's ligament in this area?
Just
where do you find the Cooper's ligament?
Just
Where it is
lateral
attached?
pubic
Where?
pubic tubercle.
Not pivotal is a point. The Cooper's ligament is a prolongation of external oblique aponeurosis. One prolongation is inguinal ligament. Another prolongation of external aponeurosis along the pecten pubis. This is the bony ridge in the superior mass of pubis, which is pecten pubis. The thickening of this ligament along the pecten pubis is the Cooper's ligament. Okay, Cooper's ligament. And if you trace this, the Cooper's ligament starts at the pubic tubercle. As you trace it laterally, how far it goes? Where does the Cooper ligament ends?
Don't know.
If you trace the Cooper ligament laterally, where does it go?
Oh, femoral canal.
Yes.
Lateral boundary of the femur.
Femoral. You see, try to understand. Femoral canal is a prolongation of the fossa transversus into the thigh. And there are 3 compartments there. If you talk of femoral sheath, I'm coming to that, that is femoral sheath. Femoral sheath has got 3 compartments. One is medial, that is femoral canal. Next is a sheath for the femoral vein, and lateral to that is a sheath for the femoral artery. Clear? So as you trace the Cooper's ligament, which is starting in the pubic tubercle and going to this ends at the femoral sheath by blending with the fossa transversalis. Clear? There is no Cooper's ligament beyond the big vessels on the lateral side. Is it clear? Yes. There is no Cooper's ligament beyond the femoral canal. So it ends there. There is an important landmark here at the femoral canal. What is the opening? You see, the other 2 compartments are occupied by the femoral vein and the artery. The medial compartment is empty. So there is opening there. What is the boundary of that opening and what that opening is called as?
Femoral canal.
No, femoral canal is a canal. The opening.
Femoral ring.
Femoral ring. Good. The femoral ring. What is the boundary of the femoral ring?
Anteriorly.
Yes.
Iliopubic.
If you go from the perineal aspect, it is iliopubic tract. You're right. If you come from the front, it will be inguinal ligament. If you go from the back, you look at this interperineal aspect, it will be iliopubic tract, and below will be
fossa transversalis.
No, below will be Cooper's ligament, because Cooper's ligament curves and is blended with this femoral sheath structure. So the boundary of the femoral ring will be anteriorly iliopubic tract, or if you're looking from the front, it will be inguinal ligament, and below is the Cooper's ligament. If you put your finger in the femoral ring and take your finger towards the medial side, where this finger will hit?
Pubic bone.
No. What structure it will hit? It will hit the lacunar ligament. Try to understand. The boundary of the femoral ring is not pubic tubercle. There is another ligament which is prolonging between the pubic tubercle and the Cooper's ligament, and between the inguinal ligament. That structure is called as lacunar ligament. This lacunar ligament lies between the Cooper's ligament and the inguinal ligament. Okay. So if you put your finger in the femoral ring and want to come medially, your finger will hit the lacunar ligament. If you take the finger laterally, where this finger will hit?
Femoral vein.
Yes. So this will hit the septum. This will hit the septum between the femoral vein and the femoral canal. So this is the femoral ring through which hernia may occur. What is that hernia?
Femoral hernia.
Femoral hernia. Clear? So if you look at these hernias, the indirect hernia, direct hernia, and the femoral hernia, they are all in a area which is very close by. Okay. So what is the demarcating line between the indirect and direct hernia?
Yeah, Hasselbalch triangle, inferior epigastric artery.
Inferior vessels. You see, if you divide the vessel, what happens to this boundary? Nothing. So this boundary between the direct indirect hernia is not a very defined tough structure. It's a vessel. If you dissect a femoral hernia and push it towards the interior, where does it go? It goes to the Hasselbalch triangle. Clear? So basically a prolongation of the abdominal content, if it take exit to the femoral ring, it becomes a femoral hernia. If you take exit to the superficial ring, it becomes a inguinal hernia. Okay. So that's why it is now said that all hernias in this area occurs through a common orifice. And that orifice is called as myopectineal orifice or a Fouchard. And all the groin hernias, indirect hernia, direct hernia, femoral hernia, all occurs through this orifice. So now if you go into this orifice of myopectineal orifice of Fouchard, what are the landmarks? What are the boundary of the myopectineal orifice of Fouchard? Again, uh, you have floor, you have roof, you have lateral medial. Boundary of myopectineal orifice of Fouchard.
Laterally by the lateral border of the rectus abdominis.
No, laterally. Laterally, how can
Medially.
laterally come the rectus? Medially.
Huh. Lateral border of the rectus
Medially is a
abdominis.
lateral border of rectus sheath. Don't say rectus abdominis muscle. Try to understand. If you look at this area, rectus muscle is covered by rectus sheath. So medially, it is the rectus sheath. Laterally,
Laterally iliopsoas muscle.
yes, good. So medially is the rectus sheath. Laterally, the iliopsoas muscle. What
And
is
superiorly
the
is conjoint tendon.
good? And below is the
Pecten pubis.
pecten pubis covered by what ligament covers the pecten pubis?
Cooper.
Cooper's.
Cooper's ligament.
Yes, Cooper's ligament. So that is the area. Myopectineal orifice of Fouchard is the common opening through which all abdominal contents goes to the thigh and some venous structure and lymphatic come from the thigh to the abdomen. And all the hernias in the groin occurs to the myopectineal orifice of Fouchard. And if you go into the concept of laparoscopic repair of hernia, here we cover the whole myopectineal orifice. But if you go to the open hernial concept of Liechtenstein, we don't cover all these areas. You fix a mesh to the inguinal ligament. So you are not covering the femoral ring area. Okay. So it is said that the laparoscopic hernia repair covers the whole myopectineal orifice of Fouchard rather than covering only the inguinal canal. Okay. So these are the important landmarks in anatomical discussion that it can be asked even during a long case discussion, may not be in the operative. So you must be very conversant with the inguinal anatomy, both anterior inguinal anatomy as you go by Liechtenstein approach. Second is as you go into by the laparoscopic approach, either TAPP or TP, you will come across these landmarks. The inguinal foci, the ligaments, and the important structure, and lastly the myopectineal orifice of Fouchard. Okay, so with this, we will pass on to the discussion on steps of Liechtenstein hernioplasty. Okay, so Dipang, you just, this will be an exam scenario. You just describe. I not stop you unless you are not proceeding. I give you some time to describe the salient steps of Liechtenstein hernioplasty. I'll prefer you to make a small heading and then describe what I'm trying to describe. Like that, skin incision. Next is division of subcutaneous tissue. Make small headings and then describe what we're going to do in this particular subheading. So describe the steps of Liechtenstein hernioplasty.
Yeah, first, the type of anesthesia we choose, we can nowadays it is preferred to do the Liechtenstein hernioplasty under local anesthesia with intravenous sedation or MAC. And
In your center, does your consultant do all the hernias under local anesthesia?
no, few cases.
Few cases. Then why do you start with local? You see, if you are, because next question I'll ask is the local block. Got my point?
Yes, sir.
If you say local, I'll ask you the next question, local block. So if you are doing regularly, you can jolly well tell me the local point blocks. Or it will save that. You see, in exam, it's not choice. It's a practical examination. You are facing the examiner, taking a card. So the best is to answer the what is being most commonly done. Say regional anesthesia is well accepted. Now patient is high risk, patient cannot tolerate regional anesthesia or general anesthesia, then comes the local. Because
Yes.
once you say local, I'll be interested to know how do you block locally. Because the standard teaching for open hernia repair is the best is local anesthesia. But you have to know how to do the local block. Okay, and don't say in the exam I can do GA, I can do local, I can do regional. Say one thing. If you say anesthesia, I consider giving the patient regional anesthesia. Fine, spinal anesthesia. Next.
Then position is supine with hands by the side of the patient, and pre-op antiseptic shaving and draping of the patient, and incision is
The
given.
shaving doesn't come on the table. Shaving is in the ward. Patient on table. What do you do?
Antiseptic draping of the patient.
Yes, anesthetic cleaning and draping.
And incision is given 2 centimeter above and parallel to the inguinal ligament from the pubic tubercle laterally up, yeah, more than 10 centimeter just beyond the deep inguinal ring. Then subcutaneous tissue is dissected.
10 centimeter
Superficial.
incision may not be required. You understand? Your inguinal canal is 4 centimeter.
Yes.
So if you are going beyond the deep ring, it may not be 10 centimeter incision. Okay, that depends on patient body habitus. Don't need to mention the length. Our idea is to start the incision of the pubic tubercle, go parallel to the inguinal ligament, and go beyond the deep ring. That's it. So the length will be depending on the patient body habitus. Fine. Skin incision. Next. Keep on describing.
Subcutaneous subcutaneous
Yes.
tissue is dissected. Superficial fatty camper fascia and superficial epigastric super and deep membranous layer, uh, which is fascia of Scarpa. Here we can encounter superficial epigastric vessels, eh, superficial epigastric vein, and superficial external pudendal and superficial circumflex iliac veins may also we can
Why
encounter.
we are really saying veins only? I am noticing that you are all the time saying only veins. Talk of vessels. Both runs
Okay.
together. Understand?
Yes.
When you are incising, both artery and vein runs together.
Yes.
But you are specifically saying only veins. Say vessels. So we shall be visiting vessels.
Then external oblique aponeurosis is
How do you tackle these small vessels?
we can diathermy it.
We are doing diathermy. That's say. We just buzz these small vessels. You need not ligate these vessels with a suture. Okay,
Yes.
fine. Next.
Then external oblique is incised and cut with a small nick with a blade, and then it is extended medially up to the superficial ring and laterally till the beyond the deep ring,
Good.
till the deep ring, and then it is the external oblique is dissected, separated from the internal oblique, and we yeah, the above the external oblique a plane is created, and in the lower
Right.
side we dissect till the inguinal ligament to for the
So
placement of the main.
now once you incise the economic aponeurosis, you have two flaps, the upper
Yes.
flap and the lower flap.
Mm.
The upper flap is lifted up
Yes.
and you delineate the area of conjunct tendon medially and make a space between the upper flap and the internal oblique muscle.
Yes, sir.
Lower flap is dissected and what do you expose lower down?
Inguinal ligament,
Starting from medially,
pubic tubercle,
yes, and laterally beyond the deep ring. So
beyond
that
the
is what you do. Once you incise the economic aponeurosis, you have two flaps. The upper flap is raised to expose the congenital medially and create a space between the internal oblique and the external oblique aponeurosis. And lower flap is raised to delineate the inguinal ligament below, right from pubic tubercle and beyond the deep ring. So inguinal canal is exposed. Next heading should be
we mobilize the cord.
dissection of, next heading should be dissection of the hernial sac.
Yes.
What is the step?
First, we mobilize the cord from the pubic near the pubic tubercle, and then we splay the cord structure.
No. You are using half words. You don't mobilize the cord only. You assume this as a inguinal hernia. So there is something else with the cord structures. Once you start dissecting the cord and lift the cord from the posterior wall, what you lift? You lift the cord structure and the, where is the hernial sac? Yes.
Sac.
So you lift up the cord structure along with the hernial sac and free it from the posterior wall. If it is a indirect hernia, this you can do up to the deep ring. Yeah, assume this as indirect hernia and describe what you're doing next. So the cord structure with the hernial sac is lifted up in between your two finger from cervical ring up to the deep ring. Now in your finger grip is the cord with the hernial sac. What you're looking from outside in now? What is the outermost layer looking at now?
Yeah, cremasteric muscle.
Yes. Cremasteric muscle and fascia.
Internal
Deep to that.
Yeah. Internal spermatic fascia.
Yes. Deep to that.
Then the sac.
Sac. And the cord structures. Okay. So
Yeah.
as you lift up the cord structure with the hernial sac, you dissect it from the cervical to the deep ring. And then the next step is dissection of the hernial sac. How do you do that?
We splay open the sac.
See, unless you divide the cremaster, you cannot splay. So you have to incise the cremasteric muscle and fascia. You incise the internal spermatic fascia. And then you splay. And what do you do by splaying?
We protect the cord vas and the gonadal vessels.
Protection. Second is, as you splay, you see the shiny margin of the.
We dissect, we identify the sac.
Yes, you do see the shiny margin on the hernial sac. As you splay, you see the shiny margin on the hernial sac and pick it up with a pair of hemostatic forceps.
Yes.
And as you dissect, what is the relation of the indirect hernial sac with the cord structure?
It is anterolateral.
The sac is anterolateral or cord is anterolateral?
Sac is anterolateral to the cord.
Yes. So as you dissect the hernial sac from the cord structures, you try to dissect the hernial sac as it goes to the deep ring. So that remains anterolateral to the cord. How far you dissect distally and proximal?
Distally till the if it is a very large hernia, we may incise in between.
So if it is an incomplete hernia, you can deliver the fundus into the inguinal canal. That is one. So complete distal dissection up to the fundus. If it is a complete hernia going to the bottom of the scrotum, you may choose to dissect in the middle of the cord structures, and then divide the hernial sac, keep the distal end open, and held at the proximal end. What is the proximal dissection?
Yeah, medially till the neck of the sac.
Neck of the sac. How do you identify the neck of the sac?
There is a collar of fat pad, preperitoneal fat.
And as you are starting dissecting the hernial sac, what happens to the sac at the neck? Same dimension?
No, it is narrow.
Yes. So it's a constricted part of the sac.
Yes.
Is a constricted part of the sac. There will be a color of fat pad, and 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 as you reach the neck of the sac, you will find one vessel crossing it.
Inferior epigastric artery
Yes.
is medial to the.
So as you find the epigastric vessel touching the hernial sac, that is the area of the neck of the sac. Neck of the sac is identified by three important landmarks. One is the constituted part of the sac. There is a collar of fat pad, there is the extraperitoneal fat, and the inferior vessel will be seen crossing it. Okay, so you have this is the hernial sac. What
Then we can reduce the sac, or we can open the sac at the fundus and uh, push, yes, reduce the contents of the sac, and then transfix the sac with the.
when you will not transfuse the sac, as you open the sac, you ensure there is complete reduction of the hernial content,
Yes, sir.
and then only you can transfuse the neck of the sac.
Hmm.
When you cannot do a conventional transfusion of the neck of the sac, it will be in problem. In which circumstances?
uh, Incarcerated.
Incarceration, so
We will.
unless you reduce, you cannot do the neck transfer section.
Oh,
Even you
yeah.
reduce the content, the posterior wall may appear bulky. Why? You have reduced the content, but the posterior wall of the hernial sac is appearing bulky. Why it can be bulky?
Direct comp.
No. Bulky means this is another variety of hernia, which is called a sliding hernia.
Achha.
Okay. If you find the posterior wall of the hernial sac is bulky, it can be a sliding hernia. That means one viscous may be there in the posterior wall. Maybe the bladder, maybe the cecum, or on the left side, maybe sigmoid colon. So if you start transfixing and dividing, it will divide that particular viscous. So with a sliding component, don't try to do a transfusion and excision of the sac at this point. So you have to dissect and reduce the sliding component in the peritoneal space. Okay. Otherwise, you do a conventional dissection, ligate the neck of the sac, and excise the redundant sac. So this is known as herniatomy. Now is if you go by conventional Liechtenstein repair, as you dissect the hernial sac, now you have exposed the anatomical structure already. Below is the inguinal ligament, above is the conjoint tendon, medially is the pubic tubercle, laterally you have gone beyond the deep ring. Okay. So how do you reinforce? In Liechtenstein, how do you reinforce the posterior wall?
We reinforce the posterior wall by the mesh, placement of the mesh. We can choose to close the fascia transversalis, 2 layers.
You see, in standard Liechtenstein, this step is not there.
Yes.
In a large direct hernia, you have to plicate the sac, because in direct hernia, we are not excising the sac. In a large direct hernia, you can plicate. You can plicate, and on plication, you can reduce the direct hernial sac. Okay.
Yes.
Because in a stand, if you are describing a Liechtenstein repair, don't say I will do a plication of fascia transversalis. This often you do if the sac, if the wall is very redundant.
Yes, sir.
So in Liechtenstein, it's a tensionless repair. Liechtenstein repair is a tensionless repair where you place the mesh, and this mesh has got a medial border, has got a lower border, has got a lateral border, has got an upper border. Okay, 4 borders. How do you apply the mesh?
At first, we prepare the mesh by cutting it.
The mesh has to be split. The mesh has to be split laterally.
Yes.
Okay, you cut the mesh lower 1/3, upper 2/3,
Mm.
starting from the lateral end, and going up to the middle and see at what point the cord structure comes. This split is to accommodate the cord. Clear?
Yes.
This split is to accommodate the cord. So you split the mesh, lower one third, upper two third, and take the mesh to the canal. And you should change your gloves, because it's a convention to change the gloves, because you have handled the hernia and you have uh, touched the skin to large areas. So change the gloves and take the mesh. It's a polypropylene mesh, 6 inches by 3 inches. Okay, 15 by 7.5 centimeter. Okay, now comes the fixation. How do you fix the mesh?
At first we take a bite at the pubic near the pubic tubercle.
Yeah.
Medially, and then continuous suture at the lower margin of the inguinal with the lower margin of the inguinal ligament, extending up to
So the
the.
lower marginal mesh is fixed to the inguinal ligament.
Yes, sir.
Lower margin fixed to inguinal
Beyond
ligament, and
till
then
the deep ring,
medial.
and then medially, yeah, continuous suture in the lower margin, and then
No, no,
interrupted.
no, 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 no. Continuous हो गया.
Hmm.
Lower border is fixed. Then there is a medial border of the sheet mesh fixed to
Then rectus sheet.
rectus sheath. Good. You take one bite.
Yes,
One
sir.
bite from the middle border of the mesh to the rectus sheath.
Hmm.
And the upper border is fixed to
Conjoint tendon.
conjoint tendon. You have already split the mesh. What do you do with that?
We yeah, we take few bites over the
What do you have to do? You have split the mesh. So the lower flap and the upper flap of the mesh. So as you
we
start suturing,
approximate it
you have to
beyond
take
the
you
cord
have to
structure.
take this around the cord. Yes. So as you have split it, you take this two flap around the core structure, and then you oppose this cut margin,
Yes.
leaving behind a gap, to accommodate the spermatic cord. Clear?
Yes.
So you leave behind a gap for spermatic cord, and then suture this split laterally.
Yes.
So that fixes your mesh.
Hmm.
What next?
Next, we close the external oblique aponeurosis.
Yes. And then skin and subcutaneous tissue.
Yes. Yes.
I think we should discuss the lab repair another day. Okay, we are not discussing lab repair today, because we have some more discussion on the open part. So
Yes.
if it is a direct hernia, how
Yes.
does a direct hernia repair varies to some extent from the indirect? In indirect, what you have described is you pick up the cord structure with the mesh in between your finger.
Hmm.
In direct hernia, can you do that?
No, sir. The posterior wall is
Because
bulging.
direct hernia, you cannot take the whole sac in between your fingers. It
Yes.
is arising, it is coming from the Hasselbalch triangle. So what you do is, in direct hernia, you dissect the cord structure from the hernial sac, which is lying posterior medial to the cord.
Hmm.
Is posterior medial to the cord. The direct hernial sac lies posterior medial to the cord. So you have to incise the cremaster muscle and the fascia and the intersphenotic fascia and separate the cord from the direct hernial sac. If direct hernial sac is small one, you can put the mesh directly. If direct hernial sac is redundant, projecting towards the cervical ring, in that case, you have to plicate. You have to plicate to invert this direct hernial sac into the inguinal canal. Okay. So you need to plicate the direct hernial sac. And the
Yes.
next step is same.
Hmm.
The placement of mesh, fixation of mesh is same.
Yes.
Okay. What are the complications of hernia repair? What are the complications of hernia repair? Open hernia repair.
Intra complications may be bleeding, infection, Bleeding,
How can be
injury to,
infection intra? You
sorry,
cannot see intra infection that cannot come within half an hour time.
bleeding,
Infection
injury
should be post-op
to,
complication. You studied the statement of intra complication. So
mm,
intra there will be some more complications. One is bleeding. Yes. What else?
injury to cord structures,
Yes. Injury to
muscular
cord structures.
vas difference
And
injury,
yes.
mm,
And if you are not cautious and there is a lot of contents in the hernial sac,
injury to
you can
bowel
yes,
or
injury to bowel,
contents of the
injury to
sac like
bladder,
bowel, bladder,
injury to bladder.
mm,
Okay.
or there may be
And
nerve.
we have seen more complications. People who are trying to fix the mesh to the inguinal ligament has taken bite through the big vessels.
Yes,
Patient required amputation. Understand? These are very rare complications, but we should always keep in mind that there is a possibility of big vessel injury also.
yes,
If you are not very conversant with the anatomical areas, while fixing in the inguinal ligament, deep inguinal ligament is what? Femoral vessels.
mm,
Okay. So you
yes,
should be cautious while fixing the mesh also. To interrupt completely bleeding and injury to some structures, maybe
okay.
viscous, maybe vessels. Okay. And then
Post-op complications, there may be early, there may be seroma, which is very common, or
even bleeding. Intra, you said there is no bleeding. In the ward in the evening, you find patient has got a hematoma.
yes,
So bleeding is also a post-op complication.
yes, sir.
Bleeding. What else?
Se- Seroma, urinary retention,
Yes.
or there may be infection of the local surgical site infection, or there may be mesh infection.
Yes.
Late late complication may be chronic pain, or
Yes. Chronic
recurrence may be there.
inguinal pain, now described as inguinodynia. We'll come to that. So chronic groin pain is another important complication of groin hernia repair. Then
Recurrence may be there.
recurrence. So these are the important complications of groin hernia repair. And one of the important uh, complication is described as inguinodynia or chronic groin pain. What is the criteria? Some patient may come to your OPD after 7 or 10 days with having pain. It's not chronic groin pain. It's immediate post-op pain. When you scan this patient has got chronic groin pain.
If it is persisting more than 3 months after the day of operation.
So patient having persistent pain in the groin following hernia repair, which is persisting beyond 3 months.
Hmm.
Interfering with his daily activities. That is chronic groin pain. What are the important causes which can cause this chronic groin pain? What are the important causes?
It may be due to the nerve injury,
One
like
is nerve
iliopsoas.
injury, or second is while
Yeah,
putting
nerve
sutures,
entrapment.
while putting this and nerve entrapment.
Yes.
Okay, it can be nerve injury or it can be nerve
Nerve.
entrapment. Nerve entrapment causes more chronic pain than nerve injury. If you just divide the nerve, patient may have anesthesia and pain for some duration. But if the nerve is entrapped, the chance of chronic pain is more. Okay.
Yes.
So how will you treat this patient? Patient is coming to you repeatedly and patient is having chronic groin pain. How can you treat this patient?
We can use what we do. Kenacort and local anesthetic agent is infiltrated in the.
First is not Kenacort. They don't. First is not Kenacort. First is analgesics.
Yes.
Patient having chronic groin pain, started the simple analgesics.
Yes.
Study analgesics. See what is the response.
Okay.
If he is not responding, patient may be given some neuromodulators like gabapentin.
Hmm.
Okay. And then intractable pain, patient is not relieved with anything. What should be next?
Uh, then yeah, steroid
Well, steroid, you mean. Okay.
or we can otherwise we can also do CT or MRI to identify any problem of mesh is there or not?
You mean the mesh related complication.
Yes.
Okay, you cannot diagnose a nerve entrapment by doing CT or MRI. What you
Yes.
can see, there may be some meshoma. Mesh get crumbled up, mesh is causing
Hmm.
uh, compression, local structure, mesh is infected, that you can see.
Yes.
Otherwise, as a last resort, you can do neurectomy.
Okay.
Describe as triple neurectomy. The last resort for persistent joint pain.
Okay.
Okay. So we'll be discussing the lab some other day. So
Okay, sir.
what I've tried to describe today is basically you should be very conversant with the anatomical disposition of this groin area,
Hmm.
and then you describe the operative steps. Any question from anybody? Okay. Dibang, you have any question?
No, sir. Thank you, sir.
Okay.
Sir, in open hernia, one
Yeah.
question. In open hernia, we have to learn about the non-mesh repair techniques. Which ones?
You see, you have to read, but I don't think in the exam operative you will given a card to describe repair. No, I did not find any exam center they have a card like that. For discussion, yes. With the non-mesh repair. Because you see, if you go to the shoulders repair, they are doing it in all patients. Shoulders repair is a standard repair in Japan. They are doing it in thousands of patients. Apart from these, there are some other tissue repair. It should be conversion. But I did not find that people are giving a card of basinage repair or shoulders repair. Okay, you must read. Yes, I agree. Lichtenstein is one gold standard for repair, but one should be conversion with this other repair like modified basinage repair, shoulders repair, modified shoulders repair, Cooper's ligament repair, or McVeigh repair. So it should be conversion with this tissue repair also. I agree. Yes.
Okay, sir.
Okay. Thank you.